Well, thank you for joining us for the final day of Lausanne for a very important day-long discussion of advancing global patient access to the Alzheimer's innovations we've discussed the last 2 days and the future ones. We need to discuss as well the real-world evidence that is needed as we learn from product going on to market, and we also need to understand what payers need to know to make reimbursement decisions. Obviously, that is rather critical to the affordability of products to consumers and to those families who need the products. And so these are critical discussions and sort of the last mile of getting product to as broad a market as possible. We're also going to hear later in the day from CEO Michel Vounatsos of Biogen and the chairman and CEO Naruo Naito of Eisai on why access to new innovation matters and their respective efforts and their respective perspectives on how to help those living with Alzheimer's and their families. Now, to start us off today, I'm a group of experts in a discussion on first the cost of AD, or shall we say, what's the consequence of not acting and intervening, the potential impact of an intervention, the potential impact of prevention measures, and how best to model the value of interventions. Let's start with brief 30-second introductions of the panelists. David Bloom, can you introduce yourself?
Thanks, George, and good day all around. I'm David Bloom. I'm an economist and demographer by training on the faculty of the Harvard T.H. Chan School of Public Health, where I'm based in the Department of Global Health and Population. At Harvard, I serve as faculty director of 2 programs, the program on the global demography of aging, which is funded by the NIH, and the Value of Vaccination Research Network, which is funded by the Bill and Melinda Gates Foundation. I'm happy to be here today.
Thank you, David. Dorene?
Good morning, everyone from Boston. I'm Dorene Rentz. I'm a clinical neuropsychologist by training and a professor of neurology at Harvard Medical School. My predominant work is actually in helping to design outcome measures for asymptomatic preclinical Alzheimer's disease. I work closely with Risa Sperling and Keith Johnson in the Harvard Aging Brain Study, which has helped to inform the field about the earliest changes related to Alzheimer's disease.
Thank you, Dorene. Charles?
Hi, everybody. I'm Charles Makin. I lead the medical health outcomes research team at Biogen. My primary focus for research over the past couple of years has been in Alzheimer's, so this is an area very close to my heart. And in general, a lot of the focus of my work over my career has been in using evidence to understand the value of medicines. Happy to be here.
Great. Thank you, Charles. Sue Peschin?
Hi, everyone. I'm Sue Peschin, and I serve as president and CEO of the Alliance for Aging Research. We're a U.S.-based nonprofit organization, and our mission is to promote research as a way to enhance aging and health. Do that through both public policy and health education, and we work quite a bit on issues related to value of innovative treatments. So it's great to be here.
Thanks, Sue. Certainly last, but certainly not least, Inamura-san from Japan.
Thank you, George. Good evening from Tokyo. I'm Inamura Takuma, Director of Healthcare Industry Division at Ministry of Economy, Trade and Industry, Japan. Today, I'd like to introduce our project of trial for prevention of dementia. Thank you.
Thank you. This is all your panel. So let's first hear a few minutes of comments from each of our panelists, recommendation about what can be done here, and then we'll begin a Q&A. So David, let's begin with you and the work you're doing to evaluate the cost of Alzheimer's disease.
Thanks, George. So I am currently preoccupied by work on Alzheimer's disease. That preoccupation is rooted in my feeling simultaneously distressed and mystified that such a significant global health issue continues to fly so far below the world's radar for awareness and action. My view here is that the challenge of Alzheimer's disease and related dementias, what I'll refer to as ADRD, that challenge is truly colossal. It's colossal because it involves large numbers of people experiencing a relentless diminution of memory, cognition, and social skills that's progressively devastating to both them and their families. But that's just the tip of the iceberg one sees when one attempts to size the full societal burden of ADRD. Sizing that full burden involves taking account of myriad other factors, like, for example, the shadow cost of intensive informal caretaking, the foregone value of productive non-market activities of people with ADRD, and as another example, the burden of ADRD-caused comorbidities. And I would say that the future outlook for ADRD is also rather grim, as all business as usual indicators point to these various burdens I've just mentioned increasing rapidly in the coming years due to increasingly large size cohorts reaching advanced ages and also to increasing longevity. So humanity is doing well with respect to adding years to life, but not so much when it comes to preserving the quality of life in those added years. And Alzheimer's disease is a major contributor to that failing. Right now, the burdens of ADRD are heavily concentrated among the wealthy industrial countries. But in the coming decades, those burdens will shift decisively to what are today's resource-constrained low and middle-income countries. And those countries comprise roughly 85% of the world's population, and they are wholly ill-prepared to defend themselves against the coming tidal wave of ADRD prevalence. At the moment, a good deal of my time and effort is being directed at measuring the current and prospective burden of ADRD, not just in terms of people and their health, but also in monetary terms. In recognition of the complex and daunting nature of that particular task, and also with generous sponsorship from the Davos Alzheimer's Collaborative, I've recently assembled a crack team of researchers to work on this problem. As one might naturally expect, the team embodies clinical and academic talent and experience that runs the gamut from geriatrics, psychiatry, and public health to epidemiology, law, and economics. Now, I don't have any results or conclusions to share today, but please do stay tuned as we're aiming to have something respectable for public consumption by the end of next month. Another key part of my ADRD preoccupation and the work of my colleagues and I, another key part has to do with my interest, our interest, in gauging the nature and the scale of the global effort required to tackle the challenges faced in this arena. So for starters, it seems patently clear that a key and absolutely necessary ingredient for addressing the challenge of ADRD is resources. Resources for new discovery related to prevention, detection, therapeutic treatment, and models of care. We're starting pretty much in the basement here with, for example, zero effective therapies for treating ADRD, thanks in part to the essentially uniform failure of prior R&D efforts. And I would say it's interesting to note here that dementia is rather unlike other salient mental health issues like, for example, depression, substance abuse, schizophrenia, anxiety, and Parkinson's disease. Those conditions require much less discovery and much more the closing of knowledge action gaps. Anyway, as part of our work with the Davos Alzheimer's Collaborative, my colleagues and I are undertaking to review and approximate the cost of R&D efforts related to ADRD and to try to measure the extent to which they fall short of levels of investment that might be plausibly considered normal or optimal. For example, we'll try to compare dementia's R&D landscape and indicators with the corresponding landscapes and indicators for cancer, for HIV/AIDS, and for COVID-19. We'll also try to calculate levels of private and public investment we might otherwise expect to see given estimates or assumptions about economic burdens, reasonable rates of return, and probabilities and degrees of R&D success. And again, please stay tuned for our forthcoming results, which we hope will lay some of the needed groundwork for a new round of major dementia-related discovery. Thank you.
David, thank you very much. And we look forward to seeing the results of your work and your building on your prior work in the whole area of non-communicable diseases. Dorene, please tell us more about the recent research you've completed with the Jairus Study and why it matters to discussions about access.
Thank you, George. Well, Eli Lilly conducted this study led by Rebecca Robinson that was published earlier this year, reporting on the societal costs associated with mild cognitive impairment and mild AD. And these baseline results were the first of its kind to show how early stages of cognitive decline can economically impact both patients and care partners. And they recruited a cohort of 1,327 patients diagnosed by their physicians in clinical care with mild cognitive impairment and mild AD from across the United States. Interestingly, amyloid PET scans were also obtained to strengthen the confidence of the diagnosis. Now, the main points, some of them are not surprising, that rising costs increase with cognitive and functional severity, and that the mild AD group had the highest societal costs due to increased need for caregiver support. Caregivers spent more time assisting with basic and independent activities of daily living and providing supervision. However, the interesting part about this study were that societal costs were incurred even earlier than we expected at the stage of mild cognitive impairment. Now, MCI is a stage that theoretically presumes that activities of daily living are less debilitating or, in fact, preserved. So when this study illustrated that even in MCI, caregiver time was significantly impacted. Now, everyone in this study received an amyloid PET scan to increase confidence of diagnosis. But did amyloid imaging make a difference in relation to cost? I think when you look at the differences between the amyloid positive and amyloid negative group, you find that it was actually the MCI amyloid negative group that garnered the greatest amount of study partner time. And this was on basic activities of daily living, such as assistance with bathing, toileting, hygiene. Independent activities of daily living, such as shopping, cooking, cleaning, laundry, taking medicine, and supervision, was obviously twice as high for the mild versus the MCI group, but not different between amyloid groups. The fact that costs were incurred on basic activities of daily living in the MCI amyloid negative group implies the role of other comorbid health conditions that may be having an impact on caregiver time. The greatest overall cost driver in mild AD was informal caregiver costs involving caregiver time. In the MCI group, the greatest overall cost driver was direct medical costs, as well as study partner time and performance of basic and independent activities of daily living, suggesting an observable burden related to function does exist prior to the onset of dementia. So my impression related to this study is clearly memory loss in a loved one is not a benign event. It has a detrimental impact on caregivers and families long before the diagnosis of AD dementia. These findings validate the importance of a timely diagnosis and reinforces the emerging science that treatment, even at the asymptomatic stages of the disease prior to a diagnosis of MCI or AD, may not only benefit patients, but their caregivers as well. So George asked me to come up with 3 main recommendations to the field based on this study, and here they are. I think it's imperative that we continue to design treatment trials that begin prior to the stage of MCI in order to ameliorate the cost of this devastating disease. I think as Medicare continues to ponder whether to pay for amyloid imaging, this study demonstrates that PET imaging can increase diagnostic accuracy and allow for more focused and timely management, not only of the disease, but also of relevant comorbidities. And finally, care strategies, support, resources need to be directed toward discovering caregiver needs, even in the earliest stage of MCI. Many of these care partners are probably still working and providing for their families. We need to allocate and find support for them. So thank you very much for listening and for the opportunity to share this with you.
What a fascinating study, Dorene. Well done. So we'll get to some questions after we have these initial opening comments. So Charles, tell us some more about your analysis of current value assessments.
Certainly, George, thank you. So, as we talk about value, obviously a key component of discussing value is the burden, right? And I think Dorene and David both touched upon the burden in this area, and Dorene in particular talked about some of the societal burdens. I do want to sort of contextualize some of that as well, right, and add to some of that discussion. The costs of AD are staggering. There is no doubt. There's no debate. I think that's not something we need to even discuss in this audience. But to give you some context, in the U.S. alone, AD costs over $500 billion a year. Right, $500 billion. That's greater than the GDP of Sweden. And the annual cost of a nursing home, which is where many severe AD patients end up eventually, is in six figures a year. That's more than twice the median household income for Americans over the age of 65. But these estimates and everything else that we're talking about, all of these are primarily based upon the costs that we know of. Right? Research shows that costs actually start as much as 10 years before a formal diagnosis. There's a paper that's published in JAMA online just earlier this week that shows missed credit card payments or missed payments on credit accounts as early as 6 years prior to diagnosis. Missed card payments, subprime credit scores, some of the areas that this paper gets into. We have seen in the early 2000s or in the early 2010s, how does that pan out, right, in general in this country? People with subprime credit card scores, they pay more. At some point, they lose their ability to pay. It's a spiral that costs not just the patients and their families, but society a lot. Right? So we have that. And then the costs are complex and dispersed. I think Dorene made some wonderful points around that. I mean, some of these costs are easier to understand, like medical costs like ER or hospitalization and institutionalization costs. But it's actually the non-medical costs that are the key drivers here and make up the bulk of the cost in this area. Productivity losses in patients themselves, early retirement, workforce impairment, and so on, but also the unpaid caregiver time, right? Reduced productivity on the part of the caregivers. A patient in severe dementia needs about 10 hours of care a day, right? This care in total for patients in the US alone adds up to over 18 billion hours of unpaid care, which is valued at over 230 billion annually. So we have a unique disease where the burden, where we know the costs are staggering. We know that the costs we can even quantify are only a proportion of the actual costs, and that these costs are complex and dispersed, right? Oh, and then we have a disease without a single drug available to stop, prevent, or even slow down disease progression. So now that we have a number of promising AD DMTs in different stages of development, and therefore we are hopefully closer to turning what has been a dream so far into reality. I think a critical question we need to address as a society is that how do we value these initial innovations? And there's a lot of voices that question whether our current value assessment frameworks are adequate in general, whether they capture what is truly meaningful to patients and what they capture is even more than a sliver of value in general. But then that gets exacerbated in the area of Alzheimer's, given all the massive impact on caregivers in society as well, which hardly ever gets accounted for, right? Our traditional methods for performing value assessments are useful, but they miss some critical elements of value. From a health economic perspective, value is typically measured using cost effectiveness analyses, which then, in turn relies upon QALYs and costs as its basis. QALYs capture only a subset of benefits that may be produced by an innovation, and a number of these benefits, some that accrue to a patient, others that may accrue to the caregiver or family, and some that accrue to society at large, often get neglected. And then there's the issue of using QALYs in general in this population. AD primarily impacts an older population, and questions have been raised about whether we should be utilizing a traditional cost per QALY methodology in this area at all. So I think the question we need to address is how do we develop robust methodologies to value innovation that will impact not only the future course of medical spending, but then all these other aspects outside of the direct medical spend as well. Because one thing is certain, if payers and health systems are unable to adequately assess the true value of innovation, we as a society will be unable to appropriately reward this innovation, the innovators themselves. And that will influence future innovation, not only in AD that we have seen, but also in other therapy areas. And we have to remember, AD is a therapeutic area that particularly stands out in this regard, given the cycle of frustration we have seen here with respect to innovative disease-modifying therapies. Last thing I'll say is, in addition to the value frameworks, I think we as a society, we need to come up with a considered, thoughtful approach to ensure that patients get access to these innovations while balancing rewarding the innovators so that they're incentivized to develop new therapies over the long term. Thank you.
Very, very interesting comments, Charles. And I've got some questions that I'll come back to you with after we get through our remaining two panelists. Sue Peschin, adding to Charles' analysis, I think you have done some thinking about the value assessments in the U.S. context.
Yes, thank you, George. And I'm going to dive a little deeper into Charles's mention of the quality adjusted life years, which are known as the QALY for short. So it's, not a super exciting topic, but it's really important because a lot of times the most boring things can be the most insidious. QALYs are a health economics measure that represents the degree to which a drug or a treatment extends life and improves quality of life. And the QALY assigns a value to a human's life on a scale between 0, which is dead, and 1, which is perfect health. QALYs gained widespread use in the 1960s by the British government when they were looking for ways to ration healthcare in the National Health Service. This was when organ transplant and some newer technologies were starting to take off. So this type of rationing is very common in many European countries, and it results in access issues. They tend not to get treatments as quickly as we do here in the United States. Oftentimes they have very limited access. And there are mortality rate issues in certain disease areas like cancer. But I think the broader issue is that the use of QALYs distorts our ethical instincts because it places a lower value on people's lives due to having less years of perfect health ahead of them. And so Alzheimer's disease presents sort of the ultimate moral quandary when it comes to QALYs, and Charles mentioned some of the reasons why. Alzheimer's tends to impact the oldest old. The Alzheimer's Association finds that of the 5.8 million people with AD who are over the age of 65, that 80% are 75 or older, and more than a third are 85 or older. So not that many life years ahead of them. In addition, a lot of folks with Alzheimer's have comorbidities like congestive heart failure or chronic kidney disease or diabetes, and that further cuts their perceived value. Alzheimer's disease also involves symptomatic issues like psychosis, agitation, very, very common. We usually talk about cognitive issues, but these other issues are very significant. And so along with disease modifiers, there are treatments in the clinical pipeline to address the symptoms. But because QALYs put a premium on life year extension, they don't value symptomatics that only improve quality of life, but not length of life, as valuable as disease modifying treatments. And last, Dorene, Charles, David, I think everybody mentioned that these types of ways of value assessment generally don't recognize the burden of Alzheimer's disease on family caregivers and more broadly on society. So they, on the other side, don't recognize the value that new treatments could have in alleviating that burden. And history is a really good teacher. If you look at the National Institute for Health and Clinical Excellence, which is known as NICE, and that's the agency in Britain that performs QALY-based cost effectiveness assessments. In 2005, NICE proposed that cholinesterase inhibitor drugs for the treatment of dementia, like Aricept, be banned by the National Health Service on the grounds that their cost was too high and, quote, outside the range of cost effectiveness that might be considered appropriate for the National Health Service. And this was despite their admission that the drugs were effective in the treatment of Alzheimer's, and despite NICE having approved even more expensive treatments. So the effect was that thousands of Alzheimer's patients would have been denied the only treatment available. And that's an important thing to remember, is that at the time, there were no other available therapies to treat Alzheimer's disease. So it wasn't the drugs that were judged to not be cost effective when compared to a rival treatment, because no rival treatment existed. It was the patients who were being condemned as not cost effective to society. And why are these patients not cost effective to treat? Really, the only answer was that they had to be considered not worth helping. And if it was simply on the basis of cost alone, if the NHS simply couldn't afford the drugs, that would be one thing. But NICE said that the drugs were not cost effective in quality terms. And we're about to look at this in the United States through the Institute for Clinical and Economic Review. They're an independent organization that does quality-based cost effectiveness. They're in the process of doing a review of Biogen's drug, and they're doing even a more broad review of Alzheimer's therapies in general. And it's important to recognize that their analysis is probably not going to do a very good job of looking at the wide variety of costs, like societal costs that everybody's been talking about. Oftentimes they'll label these as contextual, but they won't be considered part of the core model. And the other thing I think is important to note is that the traditional model considers current productivity in its estimation of value. So you could have a lifetime of previous productivity, as many older people do, but that doesn't count, and nor does productivity that's not economic in nature. So we really need to develop non-quality alternatives to evaluate new treatments, and they should emphasize the health outcomes that matter to patients. So the emphasis should be on the medical products themselves. And we're also facing in the United States an embrace of international reference pricing. So the United States wants to adopt quality-based, pricing from other countries. And this is something else that my organization is trying to fight against. The most favored nation rule that just came out from this administration is something that we hope to have turned back with the new administration. And then last, I would say we really do need to ban use of QALYs in federal health programs or in private programs that receive federal money. Because we need to think about the fact that we pay taxes into Medicare, people pay their health insurance premiums, and we think we're buying into something that's going to be available for us in times of need. So what are we saying as a society when we rate people in relation to their care at their most vulnerable point? Thank you.
Well, so that really is quite worrisome, to say the least. And obviously, you've raised some really fascinating issues, which we'll get to in a few minutes when I start asking questions. Inamura-san, Japan has made prevention a key focus of its own efforts to reduce the incidence and prevalence of Alzheimer's and related dementias. Tell us why you're taking that approach and what Japan is doing to help its aging population from developing AD.
Thank you, George. As you all know, Japan is a super-age society. The 28% of our population is above 65 years old. So naturally, of course, the number of people in dementia is also high, and we have 5 million patients of dementia, and the percentage of the dementia in whole population is about 4%. I think the figure is the highest among the world. So it's quite natural for Japanese government to tackle seriously to dementia. It's not only about the issue of Ministry of Health. So we have a government-wide effort to tackle this problem. So I'm from Ministry of Economy, Trade and Industry, which is industry ministry, and our target is to have growth strategy for each industrial sector. And we think medical and healthcare sector have the potential to be growth sector. And for that purpose, we have one project which I'd like to explain today is our project of multimodal intervention trial for prevention of dementia. It might be easy for you to understand. This is a Japanese version of famous finger project by Finnish government. And we started this project this June. And the period over this project is about 18 months. So we will start this project this year and we will finish in 2022. And the leading figure of this project is Professor Arai of Japanese National Center for Gerontology, and the size of cohort is about 1,000 people, and it's quite difficult to start this project amid the COVID-19 situation. But the situation is slightly better in Japan than in US and Europe, so we can manage to get the size of this sample size. And so the target, the aim is to prove the effectiveness of multimodal dementia prevention program, which involves such as physical exercise, nutritional guidance, and cognitive training. And so once we get the result of this project, we think this will help the creation of new service for dementia prevention. And so many industry, including sports gym or food industry or care home can provide new services based on the result of this project. Unfortunately, at this stage, it's too early to provide some preliminary conclusion of this project, but I just say that we can successfully manage to start the large size of cohort, and we hope this project can prove some kind of good result, and this can, I think, including this project, we are starting many dementia projects. Some of that is involves many private companies, and Japan would like to leave to create the model for private and public partnership in tackling this dementia. So, but at the same time, we'd like to learn from other countries. As I explained, that our project is kind of was stimulated by other country, especially in Europe, and so we like to still learn from other country, and we like to provide some positive conclusion from our project. Thank you.
Thank you, Inamura-san. Let me ask you a question right off the bat. The Worldwide Fingers Initiative is now, I think, in more than 35 or 40 countries around the world. Are you linked to the efforts in other countries beyond Europe to understand what sort of prevention interventions would be most effective in different societies, so that you can compare and contrast what will work in Japan, what will work in Europe, what will work in the United States, what will work in Latin countries? So are you engaged in comparison and linking with other worldwide finger studies?
Yes, so the leader of this project is energetically working with other country, especially related to the, as you mentioned, the finger project. So we like to share our result and learn from other countries.
Terrific. David, I'm going to come back to you a second. You mentioned a number of impacts of Alzheimer's on society. many of which are more social in character. One might characterize them as social. So how do you dollarize that? How do you turn that into some, you're a card-carrying economist, so how do you try to take into account in dollar terms some of the social impacts that you described, sort of this non-market activity? Right. Off mute.
Sorry, thanks, George. Several of us have commented on the sort of caregiver intensity of addressing Alzheimer's, and I think that is certainly true. And some of the care takes place in formal settings where we can easily dollarize by looking at costs, long-term care facilities, nurses, et cetera. But much of it takes place in informal settings. And there we have actually developed, there are standard methods in economics for monetizing that. Methods typically rely on looking at the time use surveys, how much time people spend, and then valuing that time in a variety of ways. So that's one approach. Another approach is to basically look at the value to people of the kind of the different impacts of different care models, which we'll look at here too. I think what's very important here, George, is I think what we're going to try to do is to convert as much as possible of the full societal burdens to economic terms, to basically express it in pecuniary terms. And my thinking in that domain has been shaped by two examples that were professionally quite formative for me, and I think that resonate well with the comments that Charles and Sue made earlier. So first of all, was the path-breaking and successful approach adopted by UNAIDS and the World Economic Forum 2 decades ago to deal with the HIV and AIDS epidemics. And that approach basically involved getting those epidemics out of the health ghetto and recognizing and framing them as problems for economic development, problems for the business community, problems for political and social stability. The second example comes from the playbook of the World Economic Forum and the work it did with the WHO 1 decade ago on non-communicable diseases. The joint strategy that the Forum and the WHO adopted was to make the point that NCDs are more than just a health problem, that they're also an economic and a social problem and an impediment to national development. Now, my takeaway from these two cases is that expressing the burden of ADRD in monetary terms is what we need to do to give us a direct line to economic leaders. I'm thinking here of ministers of finance and planning, economic advisors to prime ministers, and so on. And it will give us a direct line to them because it speaks to them in the language they understand and in terms of the outcomes for which they're accountable, namely economic well-being and poverty mitigation. And it's important to note that these economic policymakers have the power of the purse and also the ears of a multitude of movers and shakers in the private sector. And the theory of change here is that if we can deliver messages that are customized to the interests of economic leaders, that should be a compelling way, or it certainly seems to me to be a compelling way to activate their financial muscles in terms that will support an urgently needed, aggressive, and transformational Alzheimer's agenda.
I like your thinking, but let me ask the question in a way that actually Charles's comments raised. Let us assume that an innovation, a disease-modifying drug is introduced on the market and creates this wide variety of benefits of economic national growth or national development. How much of the value of that intervention ought to accrue to the manufacturers or to the innovators? Are we looking at a system where, while reimbursement is important, whether there are other non-traditional models of benefit that can be tapped into that might be able to either reward innovators or to find other ways to stimulate innovation?
So it's a good question, George. And my basic view here is that you're asking a question essentially about pricing. And my view is that pricing should be certainly above the cost of production of the innovation, the drug therapy or the preventive therapy or what have you. It shouldn't be higher than the full societal benefit, and it needs to be somewhere in between. What we're trying to do here is basically to argue that the full societal benefit is a lot higher than what we realized before. And at least if I feel like in figuring out where within the range from cost of production to full societal benefit we locate, we'll be moving in the right direction if we at least locate the endpoints. And I think we've done a poor job of that now. I think that's the gist of, I think, what Sue and Charles are basically saying. We haven't valued these interventions properly. And I think we can, and it's incumbent upon us to do it. I think the push that Sue's talking about to move away from cost effectiveness analysis, I applaud, okay? And many of us are working on that. And I think in 5 or 10 years from now, we're gonna see a completely different approach to health technology assessment throughout the world because of the problems that Charles and Sue mentioned. We're seeing it already with regard to vaccines, which I think are kind of the poster child for this, but I think we're gonna increasingly see it for medical devices and drug interventions as well.
So, Charles, let me turn back to you. Assuming your product is approved and it is traditionally is assessed in terms of pricing at a certain point, but the value of that intervention to society is greater than the price of the product reflects. Are there other ways beyond traditional reimbursement models to reflect that value back to you or to the industry more generally, so that in fact we both recognize the value of the intervention and the ability of the innovator to earn an appropriate degree of profit, but at the same time find other ways to stimulate innovation above and beyond the pricing that is set for the product?
Thank you, George. That's a very nuanced, layered question with multiple aspects to that, right? And let me try and address that. I think there's a couple components to that, but let me try and address that on a broader level rather than just focusing on our product. You know, our product is, as we know, is right now it's submitted to the FDA, but we look at a long, promising pipeline in the AD-DMT space, and I think, and that's the point that a lot of the panelists have made today, that the perspective needs to shift in terms of how we are valuing these. I think you also asked a question to David a moment ago about innovation and the return to society on that innovation, right? So I think a few things for us to think about. First of all is value itself is, just like your question, it's an extremely layered and nuanced concept, right? How do you value a drug that delays your disease progression? Some will ask, how do you value your parents' ability to go out of the home independently for longer, or your spouse's ability to stay with you for longer, do ordinary things together over a period of time, right? I asked somebody, what's a meaningful delay to a patient or to a caregiver? Is it 6 months, a year, longer? What's a period of time that's valuable? They said that they once asked this same question to a caregiver. And the answer that they received was, if I can receive 1 extra hour to lay down in the day, and if I can get the value of that time, that's valuable to me, right? But let me not get carried away in that direction and stick to what we've been talking about, which is the rational sort of health economic angle of the value assessment piece. You've talked about what makes AD unique. While only 16% of the AD costs are incurred by the healthcare system, the vast majority of this cost burden is borne by the patient or the caregiver. So the benefit of any innovation will accrue across a wide number of stakeholders as well, right? Delaying progression is going to result in the patients being able to do things that they want for longer, be productive for longer. It reduces burden on caregivers, reduces medical costs, payer costs, reduce institutionalization, and then reduce societal burden, which is a point that a number of the panelists have made today. So our value assessments really need to use robust methods to include a broader set of value elements. Many of the benefits where we currently don't have a lot of data. There's an excellent paper that talks about this. It's called The Tip of the Iceberg. A lot of those benefits, they need to be captured, and that may be a very large component of the total value. There is the ISPOR value flower, which is this paper that came out a few years ago by a number of preeminent academics. That's a good place to start. A lot of elements that they talk about that aren't typically included. And then the perspective of all relevant stakeholders need to be included. So a lot of work to be done in terms of value assessments, but ultimately to me, one thing is clear. The perspective for value assessments that matters in this space is societal. There's no question about it. I think David was also alluding to that. And then the second part of your question centered upon the innovation. Rewarding innovation itself isn't an end goal, but it's a pathway to ensure that there is incentive to innovate, to create the innovation that patients can get access to. And it's not a new concept. I mean, we have seen that previously. The Orphan Drug Act of 1982 or 83, it spurred such a cycle of innovation. In the first decade after that, there were less than 50 orphan drugs that were filed for approval. Today, we have between 30 and 60 a month that are filed for approval. And we are treating diseases that we had never dreamt of, right? And there's probably no other area that shows this more than Alzheimer's disease. The industry so far has had a cycle of frustration in AD drug development. We've had over 110 discontinued investigational therapies, over 55 billion spent in R&D. And what do we have to show for it? Exactly 0 disease-modifying therapies at this point in time. Right? So despite this significant investment and progress made, a large unmet need remains. And the first approved therapy that slows AD progression is going to represent a breakthrough step in innovation. And we have seen that innovation then spurs further innovation. David referred to a couple of these areas, but we have seen this cycle of innovation play out in areas like cancer, HIV, Hep C. The first innovation sets a high bar. The next one comes, it sets an even higher bar. And we continue to go from there. So, from my perspective, at the end, all I'll say is payers and health systems' ability to assess value for any such innovation appropriately, it's going to influence a future innovation, not only in AD, but also in every therapeutic area we can think of. And after decades of failures in Alzheimer's, I'm certain that all of us truly hope that the discussion that we are having today is not just theoretical, but that it'll be put into application soon in assessing the first successful innovation in AD.
Right. Sue, ICER, you referred to ICER and its evaluation of the aducanumab product and therapeutic innovation in this space more generally. ICER has recently published its scoping document on what it's going to take into account, which was, I think, significantly modified from its initial scoping description. What is your reaction to the scope of review that ICER is going to undertake here? Is it adequate, inadequate? Is it still too quality dependent, or is it taking into account other elements like caregiver burden?
I think it's predictable. I guess that would be the most appropriate word I would use for it. ICER is very good at giving hat tips to acknowledging aspects of particular clinical areas without integrating it into its actual model. They have what they call contextual considerations, and that's an acknowledgement of broader issues than what's practical to put into a quality-based cost effectiveness assessment. So they do give a lot of airtime, so to speak, in the draft framework to the burden on caregivers. But how much of that is actually going to be integrated into the model remains to be seen. And I'll give you an analogy from a report that they put out on sickle cell disease, which primarily impacts African Americans. The contextual considerations that they mentioned there are that QALYs don't account for health disparities, they don't account for racism, and they also don't account for the fact that African Americans have a shorter lifespan than whites do. And they mentioned all of this and basically said, payers should maybe take a look at that, but that's not really, what we're doing here. So they give, an acknowledgement, but basically have a don't shoot the messenger type of attitude towards it. And then they went ahead and suggested 80 to 90% rebate rates for the sickle cell drugs, which means that, few, if any, payers are going to be taking up these newer innovations. So, the actual impact of it is there's going to be a lack of access. And I think a lot of what's done in these situations is let's try to put a thumb on the scale and see if we can fix it. So it's a very imperfect science. And it's acknowledged that it's a very imperfect science. So I think that's my initial reaction to what we're seeing.
I regret that we have too little time here to go back to questions that I had of Dorene and of Inamura-san. But we will work with all of you as we work through these issues more generally beyond the Biogen drug to this therapeutic area, because if we don't adequately incent the innovators in this space, we'll under-innovate, and that will obviously not benefit patients, which is what I am, or at least a patient family, and we will underserve society. So I appreciate the thoughtfulness of this panel, the difficulty of these issues, and appreciate your time and all of your work in this space.